Great. Well, welcome everyone. I'd like to begin by acknowledging the traditional owners on the land on which we meet today. I would also like to pay my respects to elders past, present, and emerging. Well, good afternoon, everyone, and welcome to the first FightMND Scientific Seminar of 2025. My name is Dr. Sarah Bennett, and I'm the Senior Research Coordinator at FightMND. We hold these seminars monthly on the last Tuesday of the month, and last year we heard from 10 M&D research leaders in everything from discovery research to translational and clinical trials, and also the latest in the M&D care research space. If you missed out on any of these talks, most are now available over on our YouTube channel, so you can catch up at a convenient time. Following the talk today, we are leaving plenty of time for discussion and questions. So if you would like to ask anything, please use the reaction button to raise your hand, and one of our team will enable your microphone and camera and let you know to ask your question. Alternatively, you can also type your question into the chat where our team will be monitoring and read out questions on your behalf. Please note that the chat function is only enabled if you are using the app-based version of Teams and unfortunately doesn't work on the web-based version. Please do ensure you introduce yourself and where you're from before asking your questions so we can all get to know each other. So now to our speaker for today. Dr. Anne Hogden is an M&D care researcher and the Program Director for the Master of Health Leadership and Management with the School of Population Health in the Faculty of Medicine and Health at the University of New South Wales. In addition to her research, Anne is also a lecturer in safety and quality in healthcare. Anne's background in speech pathology has meant deep experience in the healthcare space, leading to her current research interests in the development and implementation of decision tools for people living with MND. Anne is deeply involved in the M&D community, serving as a board member of the M&D Research Collective. We're grateful for her joining us today to tell us about the development and implementation of M&D patient support tools, a project she is deeply passionate about. Thank you so much for your time today, Anne, for speaking to us, and over to you.
Great. Thank you, Sarah. Thanks, everyone, for having me. So it's lovely to be here, and I get to talk about my own special work, which means a lot to me, and I hope that you guys will also be as passionate about it as I am, but no worries if you're not. So today I'm talking about how we design decision support tools for Australians who live with MND. And by Australians, I also mean across the board across the world. It's a very similar process, but ours are designed particularly for Australians. And the wonderful opportunity to pursue this project is funded by FightMND. So I'm ever so grateful for that opportunity and that funding to kick this off and make this work happen. So, oops. All right, I have to use a mouse. That's annoying. So I'd just like to echo what Sarah has already said about acknowledging country, and I'm coming today to you from Bidjigal country. So I'm in the southeast of Sydney on the coast there. And so I also pay my respects to elders past and present, and also to any people from Aboriginal, Torres Strait Islander backgrounds joining us today. So what I'm going to be talking about today is basically giving an overview of decision tools for MND care or decision-making process, then looking more specifically at decision support tools that have been developed in the MND space since 2018. Then we're going to talk more about the redevelopment project that I'm currently conducting to create new and revise the old tools that were there, and then talk about the methods and results and where we go next, and all in the space of 40 minutes. So feel free to interrupt if I bang on a little bit too long. So I'd like to introduce my lovely research team to you. Now, I'm the person leading the project, and I've stacked the investigator team with subject matter experts, because in our decision tools environment, we're looking at things related to PEG, related to NIV, and related to genetic testing. These are the tools that we knew we had and that we needed to revise. We've also got two implementation experts on there, Marnie and Karen. And so Nicole's coming from the NIV space, Ashley's coming from the genetic testing space, and Liz is a dietitian who's developed her own PEG decision-making tool. It's a wonderful website, and we'll have a closer look at that later. Now, along the way, I've had two wonderful research assistants. So firstly, Mia Bierbaum, who did our literature reviews, hopefully up for publication fairly soon. and Tunde, who is now currently working on compiling all the information we need to put into the revised decision tools. But let's get to that. All right, and we're going to just talk about the decision-making processes first, just to give a basic understanding of what goes into decision-making, particularly in MND care. All right, firstly, just this shows you, or this diagram comes from Kristen Shoesmith, who is the person who designed the Canadian MND or ALS guidelines for care. And they have a diagram in one of their papers that just shows you what clinical decision-making is all about and how that works. So by clinical decision-making, in this case, it's for neurologists, I suspect. So it's written for neurologists, and you can see they have a monitoring phase, the criteria for intervention, and then proceeding to the intervention. And it's very linear. We see it talks about BMI, it talks about values that can be, you can have numbers put on them. We can see progression. These things come off the ALS scores that are taken during clinical visits. So very linear, very straightforward, and it's kind of a yes or no stage before they progress. However, when we look at how people with MND make decisions, it's a very different process. And this modelling was the output of my PhD work. So back in, I finished this around, this was published in 2015. And what I looked at was how people with MND actually made their decisions in the clinical space. And so I talked to about 33 participants who were people with MND, their carers and health professionals, to find out what decision-making looked like in care practice. And what we found is there was a stage that was needed where people with MND and their families needed to engage with the health professionals to even discuss the decision that they were looking at. They then, once they had engaged, they then needed to know about the options that were available to them. So for something like if they were considering a PEG or a gastrostomy, they needed to know things like what will happen if I don't have the gastrostomy? How is it surgically inserted? What kind of feeds do I need? Where do I get this kind of thing from? And so a lot of time is spent in the clinic in this phase about giving people the information they need to be able to be well informed to make a really good decision. And so once people with MND and their carers have this information, they then go into a stage of deliberation where they look at, well, is this for me or is this not for me? Or is this for me right now? It's also a timing thing. Perhaps PEG, for example, had been suggested to somebody who doesn't actually have swallowing difficulties yet, but they may be fatiguing and having difficulty with their breathing. So they need to know, is a PEG something that's going to help me right now, or can I delay it for a little bit or not? And so once this deliberation or weighing up of the information and choices available to them is completed, people with MND and their carers then went into the implementation phase where this, say, for example, again, the PEG was then inserted, that kind of thing. But you can see between most of the stages, there's a back and forth. So we find that unlike the clinical decision-making that we just looked at, this form of decision-making is not linear. It goes around and around. It can stop and go backwards. And there can be some very long spaces of time between the stages. So this was the basis that set us up to understand what decision-making was all about in MND care. So once that was completed and published in around 2015, the next thing we had to consider is what can we do to make decision-making for MND care better, because we could see some obvious problems that were occurring, and we'll go over those in a little bit later. And so the result of that across, this is the international coverage of decision-making tools for MND care or ALS care, depending on what country you're coming from. There are 5 tools, well, 5 sets of tools basically that are set up to help people with MND make their decisions in line with their own personal values, in discussion with their families and in discussion with their health professionals. And so these are the sets that are currently existing. So I've just put those snips in there, and I've just also added, if you wish to go back and have a look at them later, these are the web links for that. And so most of them are English-based, but there is the Spanish tool, which looks at a number of issues in MND care, and it's written actually in Catalan and Spanish as well, but it will translate if you're interested. So they're all done in slightly different ways. There are some similarities between the tools and some differences. But in essence, decision support tools are there to promote high quality decision making, no matter what decision you're looking at or which disease context this is coming from. And so when we look at like the world international standards for decision tools, we actually come from Canada, and I've put some links in there for you to have a look at if you're interested. They state that the decision tool is designed to help people make very specific and deliberate choices about their care. The decision tool has to make the decision they're making very explicit, so yes or no, essentially. Provide information about the options and outcomes that are relevant to their health status, and to allow them to clarify their personal values. So many people will say, well, look, I don't want to be dependent on equipment to live. And they may say that before they get a diagnosis, where they are suddenly in a situation where they do have to consider whether being on some form of equipment such as PEG or NIV will actually help their quality of life. And so they have to sort of think about, where does this fit in with what I actually want for my life? And the tools are also designed for people to use them at home with their families or in consultation with their health professionals. And ideally, both those things happen, because it's really good to get an understanding of the decision that you're looking at, both from the health professional's perspective and your own and your family values and what you want. And so essentially, a decision tool leads you to a yes or no answer to a question. So, for example, should I have a PEG inserted for my nutrition and hydration? Yes or no? And the decision tool helps you to work through that decision to see what's important to you, what the risks are, what the benefits are, all that kind of thing. So you can make a well-informed and hopefully a well-timed decision. So there are essentially three components of a decision support tool. First, we have information about the intervention that people are looking at. So, for example, if it's about PEG, then people are looking at information all about PEG. What are the facts about PEG? What is known? What does the research tell us? The next section of it will talk about the benefits and disadvantages, or the pros and cons of having a PEG. And there are a long list of, well, fairly long list of both that people have to consider. So, for example, the benefits are that you will improve your nutrition and hydration for your body, but one of the disadvantages may be that you've got to care for this. It requires some maintenance. Another advantage may be that it's much easier to get the nutrition and hydration in, and you can just eat for pleasure. But the disadvantage may be that the equipment needs replacing, those kind of things. All these things have to be weighed up and then checked against your personal values. Is this the right decision for me? Is this something that I want to proceed with? Will this be helpful to me in my circumstances? And also the circumstances of your family. Very few people consider the options without taking into account what the impact will be on their family, whether it's a benefit for their carer or a disadvantage. So, why do we need decision support tools in MND care? Basically, it's to help people with MND make these informed and well-timed choices. There is an important issue of timing in MND care, particularly for people who are experiencing a fairly rapid disease progression, and knowing that they can make an informed decision at the time they need to make that decision is reassuring to them, their families, and their health professionals as well. Because for some decisions, and PEG is another good example of this, there comes a point when it's actually too late to do the PEG insertion, and that opportunity has been missed, kind of what we call a time window for that. And we aim to improve the discussion between people with MND and their families about what's at stake here. What will the having this procedure done, this intervention, what will it do for us as a family? What will it do for me? And what are the things we need to think about that will get in the way of this? But it also provides a good framework for discussions with healthcare professionals. So knowing about this tool and knowing where to find it, even if your health professionals don't know about it, if you can find these and show them the link, that it forms a basis of a conversation, something that you can talk through step by step if it's a decision that you want to know more about and that you are considering. Okay, so why is it difficult to make choices in MND care? There's a lot of reasons, and these are some of the ones that have come up in some of the research that we've looked at or some of the research that we've conducted. And often it's about acknowledging that change is happening. And so often, well, all of the time, that change is not for the better, it's actually for the worse. And so it's sort of pinpointing some deterioration. And for many people, that's difficult to consider. And it takes a bit of acceptance before you can even get to the point where you consider that decision and if that intervention is the right one for you at that time. And so this can often make for very uncomfortable discussions for people with MND, their families and health professionals. While many health professionals do have experience in talking about deterioration of disease and the consequences of that, not everybody is trained in that. You'll find that people, health professionals working within the specialised MND clinics will have experience with that. But if you're consulting with health professionals who are outside of the MND space in community health and they don't have much experience, this may be quite uncomfortable for them and it might be fairly difficult for them to do. So that's something that needs to be looked in a bit more detail. What makes health professionals ready to raise these discussions with people with MND? And so when is the best time to have this conversation? Is it something that we do proactively with people to say, this might happen to you a little bit later in the year or in a few months down the track, and we'd like you to think about this to prepare for this possible decision? Or are we reactive about it? Do we say, okay, well, this has already happened to you. Here's the options. Here's what we could do to make things a bit better for you. So it's about pinpointing when are people ready to have this conversation. Some people are ready to talk in advance and consider and have time to think about it. Others really need to wait until the situation has arisen and then respond to that. So say with the PEG example that swallowing's become a little bit more difficult. There's a lot of coughing, a little bit of what feels like choking with food or even liquids, or taking medications has become quite difficult. So a PEG is a reasonable, a good intervention to have to sort of solve some of those problems. But that discussion may not be raised until these problems have already been arisen. So then we consider who should be involved in this. Is it just the person with MND and their healthcare professionals? How many members of their family do they want to involve, or do they not want to bring them into the discussions? So things like that have to be considered for each person in their family situation. Or is it friends, perhaps, not family members? Who are the support people that will be there for this person with MND? And so that leads on to, well, what will this decision mean for me and my family? So if a PEG is inserted, who goes to buy the feeds, who runs the feeds, when are they run, who does the care and maintenance if the person with MND doesn't have the hand function to do it for themselves? So yeah, you can see how other people may be involved in these decisions and there's an impact on them. And lastly, what happens if I say no to this? What's the outcome of that? What will it mean for me and my family if I don't want to have the PEG or the NIV or the other interventions that may be suggested? What are the consequences of that? And so these are all things we try to address in a decision support tool so that people are informed about it and what the consequences might be if they decided to go against it or decided to delay it for a little while, perhaps. There's always an alternative, so it's kind of what's the best alternative for you. Now, recently we've done some research into what actually influences the decisions that people with MND make. And what we found was very much when people with MND spoke to us about this, it was very much about their personal values and preferences and being able to choose for themselves the path that they were going to take. As I had said previously, the views on being dependent on equipment and technology were an issue for some people. Others, that wasn't so much of a problem. But one of the bigger ones was a perception of carer burden. So if we go back to the PEG example, people often said to us, I see the PEG as being something that will relieve my carer or my wife, my husband, of having to do a lot of work for me. So they're not there having to try and get food into me, to get the meal finished, to make sure I've got enough food, enough drink, enough medication in me. The PEG was a good solution for the carers to be able to make sure that their person with MND was well fed and hydrated. For other people, and these were kind of in the minority, they saw having a PEG as an additional burden for their carer, their spouse, because they had to then sort of be there involved with the purchasing of the feeds, the maintenance of the equipment, and they saw that as an extra burden they didn't actually want their partner to have. And so this led to how people perceived quality of life. What does quality of life mean to each person? It can be very, very different. For some, it means being able to participate in family activities and maintain that very important role that you have within your family. For some, they also raise, well, it will make my wife happy, it will make my children happy, that kind of thing. So sort of fitting into the family. And then what are my priorities? What do I actually want for me and for the rest of my life? Then the last thing was about changing my mind. What's important to me right now? If I proceed with this, say the PEG again, for example, can I stop it at some point? Am I stuck with this forever? Can I change my mind later down the track? So what's important to me right now versus what's important to me a little bit further ahead? And it's often very difficult to project ahead, but a lot of people wanted to toss that over and think, this is okay for me right now, but later on I might need that. All right, we'll take a step backwards into what happened in the decision tool development project that was first run in 2018 that was funded by MND Research Australia. So we received funding for a year to develop what we'd hoped to be a set of 6 tools. And basically we had 2 panels of experts, so a total of 13 participants. We kind of separated out the people with MND and the carers from the MND clinicians, researchers and MND association representatives. And then we had a decision tool designer and a human factors engineer involved, just so we could get a concept of what makes a good decision tool that is easy to use. What we found in that project is after we'd finished the interviews and the focus groups that we ran, the participants identified 56 different possible decisions that could be used as a decision tool. And so because we had only sort of funding, or we thought time for 6, we asked them to prioritise which were the 6 most important. And when we did this in Delphi rounds, we found that it was very, very clear response from them. The 6 most important or highest priority topics were very easily picked out from the rest. And so this resulted in the production of a gastrostomy or PEG tool, a tool for non-invasive ventilation, and one for predictive genetic testing. We had also planned to do one on choice of communication equipment, advanced care planning, and end-of-life care. But we ran out of money, and we ran out of, well, not time, but we ran out of money. We weren't able to continue that project. And so we just had the set of 3 tools up on the website for people to use. And this is essentially the address of the web page that is the MND decision tools that we developed as part of that project. And those 3 tools are sitting on there. And these are the ones we're overhauling. So a different website will be developed with these. So I'll just talk about that. How are we doing for time? Okay, a little bit of time left. We're doing well. So this project, again, as funded by FightMND, running from 2024 to 2026, we're about halfway through at this point. And the aims of this were to update the content format and usability of the existing tools we had developed in 2018, and to develop 3 new tools, or up to 3 new tools that would reflect the priorities of Australians living with MND. And then the second part of this was to undertake the implementation of the tools. And we had planned to do this in a sample of MND clinics, and we'll talk more about that in a minute. And then evaluate how well were the tools with their uptake, how well were they doing with uptake, and how well were they assisting people to make their decisions for improving care. All right, and based on changes to legislation and more recent MND research and technology and practice, we anticipated that some of these tools might be the new 3 tools we would develop. So voluntary assisted dying had become a thing in Australia. There were some examples of people taking up invasive ventilation rather than non-invasive ventilation. Diagnostic genetic testing was becoming a tool that's been used in other areas and in some of the MND tools as well. Voice banking had improved out of sight recently in the way that they sample voices and can put a good voice bank together. Radically changed from what it used to be. And medical cannabis had been approved by Australian legislation as well. So it was reasonable to think that some of these might be selected. So we wanted to know what would make these tools useful to people with MND and their families and healthcare professionals. And so, of course, we co-designed the tools with our stakeholders. So this was to first identify improvements to the existing tools, to design and trial the new tools, the new developed tools, and the old ones refurbished or revised, to participate in the implementation and to provide ongoing feedback after the project, so during and after the project. So we're trying to maintain good communication with our participants and stakeholders in this project so that we can keep an eye on how well the tools are doing and how useful they are. And during the life of the project, we can make modifications to them just to make sure that they're doing the job that we hope they will do. And so our research plan was basically to do the literature reviews, to update the content, just to make sure it's up to speed with what was in current research, to run focus groups with our stakeholders, which were the people with MND, their family members, health professionals, Motor Neurone Disease Association reps, and MND care researchers this time round. And to then design the new decision tool website and co-design the content and format with our stakeholders. And then to make sure they also meet the international patient decision aid standards. So again, that's what comes out of Canada, the standards that you have to meet to have your decision tool registered, which is an important thing. And it just means other decision tool developers can look in the registry and find what's been done in the MND space, or perhaps in the PEG space or the NIV space, which is actually what I'm doing to redevelop our tools, looking at what's gone before and what's working well. So this will result in building the new decision tool website, and then we'll go for implementation. So there's the plan. So the way we went about doing this was running focus groups this time instead of individual interviews, using content or inductive content analysis of the focus group data that came up, just to make sure that we were picking up all the information that our focus group members had given to us to ensure that nothing was missed, and to be able to pick trends in that information they'd given us. And that we did. People were very clear and very consistent. I'll get to that in a minute. So once we'd held the focus groups and done the preliminary analysis, we did voting rounds to choose the new 3 tools that would be developed. And it was also good to find out that the 3 current tools were voted as successful enough to stay. They weren't replaced with anything, but they picked 3 new tools to add on to those. And so then we're going to be doing iterative reviews of the drafts by our participants and the research team, and then we'll co-design the implementation plan, which will be a little bit different from what we'd expected. So when we ran the focus groups, there are actually two focus groups run. Yep. And the basic questions that I had asked people, and I got them to prepare beforehand, was, what do you think of the current decision tools that are available? And by that, I included the ones that we had developed earlier, but also the international tools to make sure that people were understanding and seeing good examples of how things had developed since our tools were developed in 2018, because they were the first ones in the MND space internationally. So other tools had been developed. Actually, I was involved with the development of all of those ones, the ones we saw on the slide, the 5 different tools. I had some involvement in those. And then once they were aware of what was exist in the existing space, to recommend updates for the current tools and to updates for the website format to make it more usable, and then to propose the 2 to 3 new tools. So essentially we had 14 participants. So it was 13 last time, 14 this time. So very, very similar, surprisingly similar. But again, they came from different fields, and you can sort of see the numbers there. Now, all but one were women. So we had one gentleman participate, but otherwise everybody else was a woman. So that was good to see across the board. And from New South Wales, Victoria, and Queensland, essentially. So, despite my anticipations of things like voluntary assisted dying and medical cannabis, the 3 new tool topics were very similar to what was proposed for the original set but weren't developed. So one of them is the advanced care planning, end-of-life care, which will include palliative care, and the new one is developed in response to what's come out in the genetic testing world, diagnostic genetic testing. Our existing tool was predictive genetic testing. So that was developed for family members to know if the MND genes they had that or not. And so this time we're looking at diagnostic genetic testing because that's become more prominent in the MND care space and research space. So that's a higher priority now to people with MND and their families than it was 5-6 years ago. So that was the result. So I sort of picked a couple of them, but definitely not all. So it was good to see. And so the summary of the changes they wanted to the content and format. So my previous tools were a bit word heavy. So the idea is to reduce the reading burden by having less text, having more in drop downs that people can choose to read, and to simplify the language. We found that the terminology was not always user-friendly. And so we'd started out with gastrostomy, but now we're changing to PEG because in Australia, PEG is the more commonly used term. Also, to go with the reduced and simplified text was using more images and videos of patient experience. And so we aim to get some videos done for people to say what their experience is of, for example, using PEG, using an IV, that kind of thing. Simplifying the format. In the current tools, there's 2 quiz sections for 2 different purposes. One of those is going to be removed because it's really unnecessary. And change the implementation plan. So while we had planned to do a trial of the decision tools within clinics, 6 clinics, that's not going to be feasible. So the participants told us, yeah, no way, that's just not going to work. And so we have to switch to a promotion plan, an awareness campaign, a marketing type strategy to get these tools up and out there so that people with MND are aware of them outside of their clinic experience and that they are able to bring them to the clinic, and that also promote directly to health professionals through their organisations and associations so that they are also aware. So a sort of a 2 or 3 pronged approach it will be. All right, so what happens next is we need to get our literature reviews published. Already done that. So the content analysis, the focus group data has been done. So this is actually what's happened, on this left-hand side. The decision tool information content development is underway, and I'm going through the IPDAS registry to find good examples of tools in other disease conditions that are really good examples of things for end-of-life care, palliative care, and advanced care planning, and diagnostic genetic testing as well. So there's a lot for me to review. And our next steps after that are to source the images, animations, and videos. There's not a lot used in most of the decision tools I've had a look at, and I just want to see how we can do that within budget and on time and get that up and sort of enliven the decision tools that were very, very word heavy. After the new set of decision tools has been developed, so that's about a 6-month process, we're going to trial them and just see how they go, first with our stakeholder group, and then once they're happy with that, we can trial them outside of the stakeholder group to sort of release them in the world and see how that goes. So we might stage that implementation, but we'll be co-designing that with our stakeholders, our participants, just to see what's the best way to do that, which are the best groups, maybe if we trial 2 or 3 groups, networks out there, and see what comes back from that. And then once we've sort of signed off on them and our participants and stakeholders have approved them, essentially, we then implement and evaluate from there. So still a fair bit to go, but we're sort of 12 months to go to complete the project. So I am very confident. And so the challenges that we've experienced are getting contracts in for our web development and implementation planning. That's a structural thing. Changes to the implementation plan. So we've sort of gone in with implementation and clinical heads in. We now have to sort of pivot to marketing, awareness, publicity, that kind of thing, which is kind of new to us as researchers. But we've got plenty of help and advice to make that happen. And then the other one that is always a part of decision tools, any sort of website, is the ongoing maintenance and costs. How do I sort of fund that and keep that going? I've had different ways of doing that for the previous website, but yeah, this one will be a little bit different, and we're hoping to come up with a plan for that as all part of this. So, I'll just flick to the reference slide. So that's there, but essentially, any questions?
Thank you, Anne. That was an amazing talk. Samar did have a comment in the chat box, and she said, "Great work, Anne and team. Great to see the new tool topics, advanced care planning, end of life care, and palliative care. And we have been hoping the time will come for these."
Lovely.
That's a nice comment from Samar.
Thank you, Samar.
So for everyone who wants to ask a question, feel free to type in the question in the chat box and I'll ask it for you. Or there's a raise hand button on the top of your screen. If you click that, you can raise your hand and Sarah will unmute you and you can ask Anne your question directly. But I might kick off with a question. I have several actually. So with the decision-making tools internationally, can you comment on how they've been rolled out and how they've been marketed? And are there any learnings that Australia can learn from them?
That is a very good question, Lynn. So in terms of the time frame and timeline of how this was done, I developed mine that had no budget whatsoever for any implementation. So nothing much happened there. It was just awareness. And I'm always surprised when people from overseas find them and come back and tell me about it. So that's been great. It's surprisingly, yeah, well seen, more than I expected. The UK gastrostomy tool was the next one after that. And they had a bit of an implementation plan, but it was clinically based. It was for the south of England. And so it was reasonably restricted. But because they were funded by Marie Curie and a bigger palliative care kind of organisation, I think they did their promotion through those organisations and the MND Association for England, Scotland and Wales. So, yeah, they sort of had kind of a lot of clinics and associations to cover, and I think the promotion came out through there. For the US tools, so they were developed by the Les Turner Foundation. So they're a charitable organisation that's attached to the University of Chicago. And they are quite a large organisation and they run regular, like you guys do, regular webinars and sessions for carers, a lot of work in the care space, and they've promoted them through that. So there's been a lot of internal work, but because they get a lot of international audiences coming to their seminars anyway, that the word sort of has gone out for their work internationally via their own channels, if you like. Yeah.
Okay, cool. Thanks, Anne. Simone from MND Queensland has a question around voluntary assisted dying. So can you provide any feedback you received about why a VAD tool was not wanted or required? Did that come up?
Yes, it did. So there were the same issues for invasive ventilation, voluntary assisted dying, and what was the other one? Medical cannabis. mostly it came down to state-by-state rules. So if these tools are developed for a national audience, then that would be very, very difficult if somebody was reading the tool, taking it to their health professionals where their state legislation did not agree with that. And so we decided to avoid anything that was typically or was controlled by state legislation, because we didn't want to infringe anything or confuse anyone. So we sort of had to push those ones aside, unfortunately, and that was very clear from our focus groups.
Do you think they'll change in the future? Like there's still going to be state-by-state regulations for all these things, but do you think down the track, if there was more funding and there was more time, do you think that would be possible?
You need a tool for each state. So yes, potentially, yes.
Yeah, okay, cool.
And if it was popular enough, it really wasn't that popular a topic, or none of them were actually. So
yeah. Okay, gotcha. And Vivian from MNDWA said that she thought the quiz section was really helpful. Would you consider keeping it, or what was the reason for not thinking about not keeping it?
Let me just clarify that. Sorry, I realise I've skimmed right over the top of a lot of things where we didn't have time for the details. Viv, with the quizzes, there's 2 quiz sections. One is the information checker and one is the personal values checker. We're keeping the personal values checker, but we don't need to include the information checker anymore. So I hope that explains that, but let me know if you need more detail on that. So one will be staying and improved, and one's definitely going. All right, thanks, Viv.
Joe from MND Vic has a question. Sarah, where are you? Joe, I think you can unmute yourself now.
Oh, I can. Magic. And this is absolutely fabulous. I'm so excited about this. We used to use those 3 tools that were on there quite a lot. So yeah, they're fabulous. My question was just around the VAD also, and just wondered whether you'd kind of bring it into the end of life kind of section, so it might still be covered within that.
It may well be, and that's a thought I had as well, because the end of life tool and incorporating palliative care, there's quite a lot of information just from those 2 things alone, but the VAD thing could also come in. It's how we do it, because as you know, we say the tools are designed to get a yes, no answer. So it's about phrasing the question that we want, but we can also include information that isn't really part of that one particular question on there. It just might be a slightly bulkier tool in the information section. We may need to add an extra page perhaps to cover that kind of thing. So it's something that I'm tossing around at the moment. And when I look at other conditions that have end-of-life care decision tools or palliative care decision tools, they're very, very specific, and it's always one aspect of end-of-life care. So we're going to sort of navigate that and find a way to include VAD in that we refer back to the state legislation and talk to your practitioners, which will probably be the best that we can do. We can provide a little bit of information, but state by state, finding the nuances out, that may sort of take us out of scope a bit, but hopefully we can get in there as much as possible. But good question, Jo. Thanks.
Thank you.
I've got another question. So with your focus groups, most of the participants were women. Do you think the stark gender difference would have made a difference into, like, if there were more men, or if there were equal amount of men and women in the focus groups? Do you think there will be a difference in what topics would have been discussed?
I think so, but it's kind of hard for me to say, because when I look at the 2018 project, it was similar. There were I think 3, maybe 4 out of the 13 were male. So it was a closer balance, but it still didn't make a difference. The voting was really, really clear. So I think, potentially not, and I would hope not. I hope the priorities are the same across the genders here.
Cool. And then I've got a question from someone from FightMND. How accessible are these resources to people living with MND in more remote areas where maybe your internet connection is not amazing? Are they all they are going to be on the website, so they will be digital, but will there be paper versions available, and will they be useful?
Yes. So what we've done with the previous tools and other tools that are available is there is a print function if you wanted to print them out, but it may be a separate thing on the first page, where if you can actually get to the tool via the internet, then you can print it out straight away. I'm not sure where to store otherwise where I can store a paper version, but yeah, that's absolutely. So a lot of people do prefer paper.
Yeah, it could be part of like the whole implementation plan as to how to reach people out in regional areas.
Excellent point. Yes.
Following on from that question is, will there be an app-based thing? Because I think about how I use technology nowadays and I'm rarely on the computer unless I'm working. But most of the time I'm on the phone. Would there be like an app-based version or a phone-based version for the tools?
That is a whole different project.
Okay.
App-based versions, we did consider this in the initial project and how we might do it as an app versus a website, and they're very different in the way that they're built, and it's very difficult. With an app, you have to take the entire thing down for any kind of maintenance, and so we decided to go against the app and go with the website because it was more accessible. So, and also when you can actually look at the web page on your phone. If you sort of Google it, you can still connect to it and you can still actually navigate through it. It might be a bit clunkier and harder to see, but it will work on a phone, but through the web browser. Yeah.
Cool. I thought I had another question, but I forgot what it was. Does anyone else have any more questions from the floor? If there's none, we might thank Anne and wrap it up. Sarah?
Yeah, thank you so much, Anne, for taking the time to speak to us today and also to answer them the questions. I think there's some real interest in this space, and it's so applicable to everyone, to everyday experiences of MND care. So thank you. Yeah, so if there's anything you'd like to follow up with Anne on, you can get it. I'm sure she'd be happy for you to get in touch directly with her. Or if you would like us to help connect you, please do reach out to us at FightMND, and we're very happy to help connect you up. So thank you so much for joining us today for the February FightMND Scientific Seminar. We hope you've enjoyed the presentation. Please do join us again next month when we'll have a new seminar, which will all be about the potential of data for enhancing research in the M&D space. So keep a lookout in your emails for news on this seminar, which will be taking place on Tuesday, March 25th. Thank you again, Anne. Have a lovely day, everybody else, and we'll see you next time.
Thank you all.
Thanks, everyone. Bye.
Bye.